Hi, today we're going to talk about hypertension. That'll be a big theme for our research this semester. And so I want to get you introduced to why it matters. By way of outline, we'll talk about what is hypertension and what causes it, how common it is, what are some common consequences for it, and then we'll talk about how some of the medications that are commonly prescribed for hypertension work. As we get started, I want you, anytime you study, to think about this. The motto for BYU is to enter to learn and go forth to serve. And I challenge you as you do your studying to consecrate your efforts, perhaps even with a prayer. Consecrate them that you can succor the weak, lift the hands which hang down, strengthen the feeble knees, and bear one another's burden. In other words, as you study, do it for a reason. Do it to try and help others, not just to master material. I promise you, as you do this, you'll find your studying much more rewarding and most likely find greater insight as you go and even potentially inspiration. So, what is hypertension? It's an exaggerated pressure of blood acting on the surrounding tissues. Now, this pressure can act outward on the arteries themselves, or it can act backwards on the heart that's pushing the blood, or it can act forward on organs downstream, like the brain, the kidneys, the eyes. These ones are especially sensitive to high pressure. Now, you've probably heard the word hypertension. So, what is hypertension? It means high blood pressure, but how is it categorized? Currently, it's suggested that a systolic blood pressure, which is the one that typically is studied most, systolic pressure less than 120 millimeters of mercury is normal, and the lower, typically the better, until you start to get hypotensive, where your blood pressure is so low that you start to black out or have problems exercising that way. Stage 1 hypertension is now defined by the American Heart Association of being over 130 millimeters of mercury. And then you start to see stage 2 hypertension over 140. If you meet a person that has a blood pressure, systolic pressure over 180 while they're sitting down resting, you really should consider telling them to go to the doctor. That's a very high pressure. And then diastolics, you can see over there as well. Now, these are at rest. That's going to be an important distinction because these pressures your systolic and diastolic pressure can go up quite a bit during different kinds of exercise. So keep that in mind. These are at rest. So what causes hypertension? At some point in your college career, you should learn this equation that mean arterial pressure or average artery blood pressure, here written as MAP, is the product of heart rate times stroke volume times vascular resistance. Or another way to write that would be cardiac output, which is often written as a Q, times vascular resistance. So as I talk about blood pressure, I will do it by referencing a pump and a balloon. Suppose that you're trying to pump up this balloon, and what's going to determine how much air gets into the balloon? So every time you do a pump, you'll be ejecting some air into that balloon. So the number of pumps you do per minute, which would be the equivalent of your heart rate, will influence the pressure of that balloon. And then if you have a small pump or a large pump, that'll also influence. What if you had a pump that was this big instead, right? So if you have a pump that big, 2 beats per minute is going to put a lot of air in that balloon versus 2 beats per minute on a very small pump. And so the amount of the amount of blood that you eject with each heartbeat is called your stroke volume. And that would be the equivalent of how much air is being ejected into the balloon with every pump. Now, vascular resistance is, in terms of the balloon, would be how elastic this balloon is. Let's imagine that the balloon, as you push air into it, it doesn't expand very well. So that means as the air enters, it's getting pressurized a lot. So if you have a very stiff balloon, it's going to pressurize. If it's very elastic, it won't. If it's a small balloon, it can't accommodate a lot of air. If you have a small vascular system, it can't accommodate a lot of blood without having high pressure. Another thing that's going to influence resistance is how big this balloon gets, right? So if I guess this is reiterating what I just said, but if you have a really small balloon, if you pump a liter of air into a small balloon, that's going to result in a really high pressure. If you pump a liter of air into a balloon that's this big, it's not going to be very high pressure, right? So our vascular system uses this idea of the size of the vasculature, particularly the resistance arteries or your arterioles are the main point here. Your body will adjust the size of the arterioles to increase or decrease the size of the vascular system and increase or decrease resistance. So if you have really high, if you vasoconstrict your arterioles, that'll decrease the size of the vascular network. So it's like making a smaller balloon, and that's going to drive blood pressure up. So let's go through one by one looking at these things. So sympathetic activity, your fight or flight response, will influence that. As you release adrenaline or norepinephrine and epinephrine, that's going to cause the heart rate to increase and the heart to pump harder, increased contractility. So both of those, the sympathetic will increase stroke volume by causing your heart to pound harder and heart rate to beat faster. So both of those will increase mean arterial pressure or blood pressure. So a person with hypertension, they might have a higher resting heart rate and higher stroke volume. They might be in a high sympathetic state. So things like stress will influence this. If you're worried about a test, your heart rate could be high. If you're scared, your heart rate and your stroke volume will go high, and that will drive up your blood pressure, probably to help you escape whatever you're scared of in that fight or flight response. Other things, though, besides these temporary things like stress, I guess chronic stress could do this also, but if you're just chronically stressed, you might have a higher pressure, but mostly it's these acute stresses that I'm thinking about, like exercise or a test or being scared. Those things can influence that acutely. But chronically, aging is a big deal here. As you age, you tend to have higher sympathetic activity. Those sympathetic nerves are firing more while you're resting, and that drives up the stroke volume and everything. And you can also have a messed up baroreceptor that's sensing your pressure and cause higher sympathetic activity. Another one, especially this will definitely be the case when we look at exercise blood pressure. The more out of shape you are, the higher your sympathetic response is going to be. The harder something is for you, the more your heart rate goes up, the more your stroke volume goes up, and that could drive up your pressure if nothing else changes. Now, what influences your stroke volume? This is going to be influenced by what we call preload. So how much blood you can pump into your ventricle, or in this case, into that pump, and also how much blood volume you have. The more blood volume you have, the more you can fill in the ventricle and the more you can pump. Both of those will increase stroke volume, and that can increase blood pressure. Other things that will influence this is fluid retention. So you have the renin-angiotensin-aldosterone system, which monitors blood pressure and the fluids in your kidneys. And if it senses a lower pressure, it will signal for increased fluid retention, which will then cause an increase in blood pressure. Also, having high levels of sodium will cause you to retain more fluid. Interstitial fluid will go back into the circulation and drive up your blood pressure because you're cramming more fluid into your circulatory system, right? So these ones, yes, they affect stroke volume, but sometimes it's easier to conceptualize their impact by just thinking you're putting more fluid into the vascular system, and so it's going to have a higher pressure. Now, we've talked a little bit of contractility. This is sympathetic activity. Sympathetic activity, your fight or flight response, is going to cause your heart to pound harder, causing more actin and myosin to interact in your heart, and you're going to contract harder and pump more blood. The consequence of that also is that you have to consume more calories, more ATP, and more oxygen in the heart to do that. And that'll become problematic as we see later. Then vascular resistance. What causes you to have a high resistance. Probably one of the first things to think about on this, we've talked about this, is how compliant the arteries are. So if you remember, if you have a very stiff balloon that doesn't like to expand, as you pump air into it, the pressure is going to drive up really fast. But if you have a very elastic or compliant balloon, as you pump air in, it increases the volume and the pressure inside of the balloon doesn't go up as much. Same idea with your arteries. If you have very compliant arteries that are very elastic, they can accommodate higher fluid content without having high pressure. And unfortunately, as you age and with cardiovascular diseases, you tend to get more stiffer arteries, so they're not as compliant. A consequence of having stiff arteries is that you get amplification of your aortic wave. As the heart pumps blood out of the heart, out of the ventricle, it travels down, a pressure wave travels down the aorta and down the arteries until it hits these branches. And as it hits branches to smaller arteries and arterioles, that pressure wave can ricochet back. And if you have stiff arteries, that pressure wave can ricochet back faster than normal, which will then amplify your systolic pressure. It will add on to the outgoing wave. You might have seen something like this at the beach. If you see a wave coming up the shore, and then it has to come back down, right? The wave comes back down once it's hit the shore. And you've seen that an incoming and an outgoing wave connect to each other and they amplify each other. That can happen with your pressure and exaggerate it. And so having stiff arteries is a big deal for that. But another one to think about with your vascular resistance is the radius of your vascular network. So if you have fewer arterioles, that's going to drive up your blood pressure. That can happen chronically. You can change the size of your network chronically by the number of arteries and arterioles or capillaries. But acutely, what we usually see is vasoconstriction of the arterioles, these small ones, not the big ones like the aorta or your femoral artery. We're talking about small ones within the muscle, really tiny, like way smaller than a millimeter, like 1/10 of a millimeter, 100th of a millimeter. We're talking small. And these can change their size and thereby increase or decrease the radius of the vascular network, or in our example with the balloon, they would increase or decrease the size of the balloon and either squeeze the air in the balloon or relax and let the air push outward. And that way you can control the blood pressure. We see this happen a lot, this change in vascular size, radius of the arterioles, particularly with exercise. And that's a main driver of differences in blood pressure between rest and exercise, along with changes in heart rate and stroke volume. Now, what causes the arteries to change size? So you have some vasoconstrictors. Some very common ones would be your sympathetics like epinephrine, norepinephrine, or your adrenaline. That'll cause vasoconstriction in most arteries, not all, but most. And then another common one is angiotensin. This one is a product of the renin-angiotensin-aldosterone system, which causes potent vasoconstriction. And this one is a very common target for blood pressure medication, trying to block this pathway. And another one is endothelin-1 or ET1. It's a very common vasoconstrictor. Now, vasodilators, two of our most common are nitric oxide and prostacyclin. Nitric oxide's perhaps the best studied. And when released by the inside of the artery, by the endothelium, it causes the smooth muscle of the artery to relax and it expands outward and dilates, and that decreases blood pressure in that way. All right, so how common is hypertension? Now that we talked about what blood pressure is and what kind of things can be manipulated to increase or decrease blood pressure, how common is this condition of hypertension where you have exaggerated blood pressure at rest? It's very common, and the prevalence of it increases with age. If you're under like 40, it's not super common, like 7 to 10% somewhere in there will have it. But as you start to get over 18 years old, or over 40, so here 40 to 60 years old, you see it's about a third of people. And then once you get over 60, it's about 2/3 of Americans will have hypertension. That's high blood pressure, here we would define it as over 130 millimeters mercury for the systolic pressure. And whether or not they're medicated, we still consider them hypertensive. It's if they are medicated and their blood pressure is back under 120, we'd consider that controlled hypertension, but still hypertension. If they are not medicated and their blood pressure is high, we still just consider it hypertension. And it's equally prevalent or roughly equally prevalent between men and women. And interesting, in the US, we see that there are some people's demographics that are more affected by hypertension than others, but just keep in mind, it's extremely common no matter what. So it's about a third of all people, of all adults in America, but if you look among the Black community in America, it tends to be more prevalent, with 40% of Black Americans having hypertension versus 25 of white and Hispanic Americans. And men and women, we see these patterns, same pattern. So it's very common in all people, but it can be extremely common in some populations. Now, it's not just a problem in America, it's a problem worldwide. So looking at these maps, this map here shows the prevalence of hypertension in the year 2000 across the world, and the darker the colors, the more prevalent it is. And so you can see, like here, like these darker colors will be like 40 to 45% of adults, right? And so you can see some of these countries in here are having really high prevalence. America's like 30% of all adults. If we looked at older, remember, it'd be about 60% of 60-year-olds. But we see it's a problem everywhere, and it's only becoming more and more of a problem. So here's the prevalence in 2010, and you can see that overall the map all over the world is getting darker, meaning a higher prevalence. And you get some exceptions, like Canada has had a slight decline in the prevalence, which is fantastic for them. But overall, we're seeing an increase in prevalence. First world, second world, third world countries. It's especially the increasing in prevalence in these lower income countries where they may not have access to medical care. So what are some of the consequences of high blood pressure? Who cares why does it matter if you have blood pressure over 120 or 130 millimeters of mercury when you're resting? What can it cause? So we'll look at some of the consequences by looking at back pressure, outward pressure, and forward pressure. So if we look at back pressure, that'd be pressure acting back on the heart, the pressure that the heart has to pump against, the more pressure there is, the more the heart has to work. So the pressure the heart generates would be like the equivalent of how much weight your muscle has to lift when you're working out. If you put more weight on the barbell, your muscles have to do more work, right? And the muscles get tired faster. Now, if you make the heart lift more weight or generate more pressure, it's doing more work and it's going to get tired, right? So that increased back pressure increases caloric demand and oxygen demand down in the myocardium or in the heart muscle, which often can be problematic because people that have high blood pressure are at high risk for coronary artery disease, which can reduce oxygen delivery to the myocardium. So you need more oxygen, but you might not be able to get that oxygen there, and so you start to get some chest pain. That will also can lead to fatigue in the heart and decreased performance, which we could learn about on future dates. And then we can see some remodeling that can happen with the heart as well. So we have, sorry, my pen is buzzing, and I'm going to pause my recording for a second. All right, sorry, my pen died, so I had to get a newly charged pen for writing on the slides here. So the increased back pressure can cause the heart to remodel if it happens chronically. So here's just a snapshot of what you would see as a left ventricle, a healthy left ventricle, or this one here, I guess. And then if you have chronic hypertension and that increased back pressure, you see some remodeling where the muscle starts to get thicker. So just as if you lift heavy weights all the time, your muscle's going to hypertrophy and get bigger. The same thing happens with your heart. If it's having to lift heavy weight or generate heavy pressure, it tends to hypertrophy and get thicker. Uh, and that comes at a consequence. It becomes stiffer, so it can't accommodate as much blood. It can't go out as far, and it might even remodel inward. So now you have a smaller area in there for blood. Both of those can have a bad impact on the heart and make it harder to pump blood, harder to fill the heart with blood, which would be called diastolic dysfunction, and also harder to eject blood, requiring more work to eject it. So if left untreated, 50% of hypertensives will develop coronary artery disease, and that's where you have that impaired oxygen delivery to the myocardium. So you have this increase in muscle here that needs more oxygen to generate high forces, but with coronary artery disease, you can't get as much oxygen there. So now you have this oxygen deficit, a supply-demand mismatch, which can lead to chest pain or angina. Now, what about increased pressure on the walls? So that outward pressure acting on the artery walls can have consequences as well. You'll see arterial wall damage. So they tend, when exposed to chronic high blood pressure, the arterial walls tend to thicken and become less compliant and more stiff. So you ricochet that blood back to the heart faster, and that exaggerates or amplifies your blood pressure. But that also can lead to things like an aneurysm or a dissection or a hemorrhage, where you see the holes or like kind of ballooning happening in the artery wall. This high blood pressure can also cause endothelial dysfunction, which is something very important for our labs research and important for cardiovascular health. The endothelium is the tiniest layer, the inside layer of cells in your arteries or your vascular system. And it is very much in charge of maintaining the cardiovascular health. It releases things like nitric oxide and other factors that will cause vasodilation and prevent atherosclerosis and thrombosis. When you have high blood pressure, that endothelium tends to get damaged and it doesn't release the healthy things that it needs. Instead, it becomes what we call activated and releases things that will accelerate atherosclerosis or thrombosis, and which in turn will cause reduced oxygen delivery, where now you can see even more pain when you're exercising, whether it's chest pain upon exertion, or it could be peripheral arterial disease, where you have decreased oxygen delivery to your skeletal muscle, and that causes a lot of pain when you're walking and impairs exercise tolerance. So here you would see is an example of coronary artery disease with atherosclerosis. So if that plaque gets big enough, no blood can get through, or a limited amount of blood gets through, and now you're not getting as much blood and oxygen as you want, and that can cause chest pain. In this case, what's being illustrated here is that you have a full blockage, which would decrease blood flow. This could happen potentially by a plaque or by a ruptured plaque that dislodges and just eventually gets stuck like right here. And now you don't get any oxygen going downstream. And so this area of the heart is going to be starved of oxygen and nutrients, and it can die. That's a heart attack. When you have something like this happen outside of the heart and the brain, that would be a stroke. Or in the skeletal muscle, it'd be symptoms like peripheral arterial disease, where you want to get oxygen and stuff in there, but can't. And so you start to get a lot of pain. If there's no blood, the tissue becomes ischemic and dies. If you can get a little bit of blood through here, then you might be able to maintain that skeletal muscle, but you would have a lot of pain as you exercise. So if left untreated, about 30% of people with hypertension will develop stroke. Now, what about the downstream pressure? So we've talked about back pressure on the heart. We've talked about pressure exerted outward on the arterial walls, but what about pressure to the organs downstream, like the heart, or sorry, like the eyes, the brain, and kidneys? Well, they're all very sensitive to these, especially are very sensitive to high pressures. And so as you have high pressure coming down into these areas, it can damage the eyes and the heart and damage the eyes and the brain. High blood pressure is one of the greatest risk factors for cognitive dysfunction, Alzheimer's disease, stroke, kidney failure, right? So you can just imagine having high pressure coming into these areas that are not built to handle high pressure. So these are some of the things that can go wrong with high blood pressure. It's one of the most common, if not the most common, risk factors for cardiovascular disease and cerebrovascular disease and kidney disease. And it's a common thing seen in many, many conditions. So now to kind of solidify our understanding of the physiology, let's talk about some of the common medications for this. To do this, we're going to look back at our equation for mean arterial pressure. So remember, MAP, or average blood pressure, arterial pressure, is the product of heart rate times stroke volume times vascular resistance. So our drugs that target hypertension are going to act on these things. So what acts on heart rate? One that has been used in the past and it's still used, but it's not in as much favor now, is an antisympathetic. So a beta blocker, like a beta adrenergic blocker, and that prevents the sympathetic system from driving up heart rate, and driving up contractility, so that you have lower heart rate and stroke volume, and thereby having a lower blood pressure. Another thing that will do this is exercise. Chronic exercise training drives down your sympathetic activity, especially at rest and during moderate intensity exercise, so that you'll see a lower sympathetic drive at rest and exercise. So you have lower heart rate response and lower vascular resistance response, and it decreases your blood pressure. Now, what about stroke volume? What's going to hit these? A lot of these will influence the blood volume and the fluid retention. So you have a lot of them working on the angiotensin, the renin-angiotensin-aldosterone system, commonly targeting angiotensin, either targeting angiotensin converting enzyme with an inhibitor of that enzyme, or an angiotensin receptor blocker, an ARB. These are some of the most commonly prescribed hypertension medications. Another one will be a diuretic, and what these do is they cause you to urinate out more fluid, which would be kind of like allowing air out of the balloon to decrease the pressure. So these diuretics work on the kidneys, and you excrete more fluid and can lower blood pressure. These are also extremely common. A non-pharmacological way to go about this is a low-sodium diet. These can help decrease blood volume. So again, it's like letting fluid out of, or air out of that balloon, and it decreases your blood pressure. And this can be quite effective, like 7 to 10 millimeters of mercury, some of the data I've seen recently. Now, what about contractility? And this is where these beta blockers or antisympathetics come in. These have been prescribed in the past, still prescribed. So they decrease your sympathetic response, so you don't have the heart contracting as hard and driving down. By blocking the contractility response, you can drive down blood pressure as well. And vascular resistance is a very common target, and these are also affected by your ACE inhibitors and your angiotensin inhibitors. So your ARBs, or your renin-angiotensin-aldosterone system, if you block that pathway, not only do you influence the blood volume, but you can also influence vascular tone or radius. And so these ACE inhibitors and ARBs prevent the vasoconstriction effect, or reduce the vasoconstriction effect of angiotensin. You also see some drugs that are endothelin-1 blockers, and you have antisympathetics like a common one be like, we won't go into that, but you have some that can block the effect of epinephrine, norepinephrine on the vasculature. Normally, for most arteries and arterioles, epinephrine, norepinephrine will cause vasoconstriction. Not all, but most of them. And so if you can block that, you can decrease the impact and prevent vasoconstriction and decrease blood pressure. Another one that's going to affect the radius, these are commonly used, nitric oxide donors. So nitric oxide causes rapid vasodilation, and a common drug is nitroglycerin or sodium nitroprusside. And what that does is you take it often sublingually under your tongue, and that has nitric oxide go into the circulation and cause all the arterioles throughout the body to relax and get bigger. So you're having the balloon expand outward, but not having more air come in. So a higher volume with the same amount of air means low pressure. So a higher volume or higher size of vascular network with the same amount of blood drops it. So the sodium nitroprusside is often taken when people are experiencing chest pain to reduce that oxygen supply demand mismatch. And another one that's going to influence the radius of your vascular network is exercise training. So exercise training can cause angiogenesis and arteriogenesis, where you get more arterioles and capillaries, thereby increasing the size of your vascular network with just more arteries, arterioles, and capillaries. But also, exercise training improves the ability of the vasculature to vasodilate. So when following exercise training, it's commonly observed that the arterioles can expand to greater sizes, or at least they can respond better to things like nitric oxide and dilate under normal circumstances. So all these factors will help with the vascular network. All right, that is it for today. Good luck studying, and remember to try and find ways to apply this to the people you meet.